It's really going back to allowing our body to survey this tumor outside of the blood-brain barrier, and then to harness the power of our immune system to attack and kill it. And I think that is should play a role. And I'm looking forward to getting the results of the trial so that we can implement it for more and more of our patients.
Welcome to this special program. Gameonglio and Imvax have partnered together to offer this great educational webinar on the future of brain cancer treatments and Imvax's IGV-001 clinical trial. With us right now is Dr. John Buchvar, who is the Vice Chair of the Department of Neurosurgery at Lenox Hill Hospital and the Director of the department's Brain Tumor Center, the Pituitary Neuroendocrine Center, and the New York Head and Neck Institute at Lenox Hill and Manhattan Eye, Ear, and Throat Hospitals. He is also the professor of the Neurological Surgery and Otolaryngology Head and Neck Surgery at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. He is also an investigator at the Feinstein Institutes for Medical Research, where he directs the Laboratory for Brain Tumor Biology and Therapy. Dr. Buchvar's compassionate cancer care was recently highlighted in the critically acclaimed Netflix docuseries Lenox Hill and Emergency NYC. Imvax is a clinical stage biotech company that develops personalized whole tumor-derived immunotherapies. One such therapy is the IGV-001 therapy, which is a personalized treatment that aims to induce anti-tumor immunity by including the patient's own glioblastoma tumor cells plus a molecule called IMV-001. Combined, these implantable biodiffusion chambers are then placed in the patient. Think of it like a combination of immunotherapy and cell therapy put together. IGV has recently completed enrollment for its Phase 2b study and is currently working on combing through all the data. Dr. Brad Elder, he is a professor in the Department of Neurosurgery at Ohio State University and the director of the Neurosurgical Oncology Department at the Ohio State University Cancer Care Center. Dr. Brad Elder received his medical degree from Columbia University and completed neurosurgical residency at the University of Southern California. He completed his oncology fellowship at Memorial Sloan Kettering in their cancer center and has a heavy interest in the development of minimally invasive surgical techniques to treat brain tumors, as well as the development of clinical trials to treat brain tumors and neurodegenerative conditions. So thank you so much for being with us today and talking about this important clinical trial, IGV-001.
As you know, glioblastoma is one of, if not the most difficult human cancer to treat. And there really are two profound reasons for that. One is something called the blood-brain barrier, which is an evolutionarily preserved defense mechanism, if you will, that protects our brain from the rest of the things that circulate in our bloodstream. So if we get, for example, bit by a boa constrictor, that blood-brain barrier will prevent that venom from getting into our brain. And of course, that's an impediment for treatment. So we have difficulty getting things past the blood-brain barrier if, for example, you have a glioblastoma. So that's reason number one. The second main reason is something called heterogeneity. The heterogeneity of a brain tumor makes it particularly difficult to target a particular cell or a mutation. So that heterogeneity makes it like a mosaic of different mechanisms to overcome treatment options. And in fact, that's what's exciting about Imvax as a trial is not only does it bypass the blood-brain barrier, and we can discuss why, but it also targets the heterogeneity of each individual's brain tumor.
So the Imvax trial, IGV-001, is a trial for patients with newly diagnosed glioblastoma. It's a personalized cell-based whole tumor immunotherapy. So for each patient, the immune therapy that's developed, the vaccine is based on their personal tumor. So it's what the personalized means in this instance. And it contains irradiated autologous glioblastoma tumor cells combined with an antisense oligonucleotide that targets IGF-1R, so the insulin-like growth factor type 1 receptor. So the intent is to help boost the immune response to glioblastoma. So the goal of the vaccine is essentially to train the patient's own immune system or to fight the cancer, to fight the tumor. So if we think about vaccine type concepts, it's unlike, say, a polio vaccine where presumably the patient has never had polio.
Mhm.
In this case, the patient has the cancer, but the aim is to try to upregulate the immune system to fight that cancer.
Okay, so it's teaching it to identify and attack the cancer within the brain, the glioblastoma cancer.
That's correct. That's the aim.
The real motivation is knowing that my team is the best, and that, Steve Jobs said innovation is not just a great idea, it's great execution. And I think when you have a great idea and we know that Imvax is a great idea, we hope to have great execution. And my team has shown time and time again, at least at Lenox Hill Neurosurgery, that they really can execute with perfect fidelity to the guidance of the trial. And it's very difficult.
Well, I think the future of cancer therapy in a large degree involves trying to harness the immune system to help fight the cancer. And this is evident in other types of cancer therapies, such as melanoma or kidney cancer, in which immune modulating therapies that are delivered systemically have had a great degree of success. Other types of immune stimulating or immune modulatory therapies, like vaccine therapies, are burgeoning, are currently being explored, and it really speaks to the science and an improving understanding of how the immune system works and how the immune system can be harnessed to help fight cancer. Well, it's different from a lot of other glioblastoma clinical trials in that it's upfront therapy. Many glioblastoma clinical trials are administered at recurrence of disease, so at which time patients have presumably failed standard of care, which is best surgical management, adjuvant radiation, and adjuvant chemotherapy. So the upfront treatment strategy is different than most other therapies. It's also different in that it's additive to standard of care. So patients don't have to choose between standard of care or a clinical trial. This is supplemental.
Mhm.
And thirdly, it all happens right at the get-go. So the first step in management of glioblastoma is maximal surgical resection. In addition to that, patients who enroll in the trial receive implantation of the diffusion chambers 2 days after surgery, followed by explantation 2 days after that. So by the time they're home recovering and awaiting starting initiation of adjuvant chemotherapy and radiation, they've completed all the different interventional steps of the clinical trial. So it isn't something that there's a constant need to have interventions throughout the trial period. The steps of the trial are the interventional steps, the therapeutic steps are all complete by the time they're discharged after tumor resection.
It's funny, patients really fall into two camps. There's the camp of patients that want absolutely any clinical trial. It's almost as if they don't really care if you say you're part of a clinical trial. They're just so happy they're going to drop everything and do the clinical trial.
Mhm.
And then you have just the opposite. You have the patient who is somewhat reserved and concerned about the experimental component of the trial. And, what's always hard, Shannon, is I have many trials where a patient said, well, how are the other patients doing? And some trials, I look at the patient and I said, you know what, you're going to be the first person we try this on. Now, and that's always a difficult conversation. And so as a provider, I need to really counsel these patients and say, this is what I would do if it were me, if you were my loved one, and here are the alternatives, benefits, and risks of it. And if it's a controlled randomized trial like Imvax, we have to go through that randomization process and what that, means. But I will tell you for this particular trial, it's been very easy, not only to consent patients, but to implement the trial at our institution. We happen to have an institution that is very easy to work with, is understanding and really bends over backwards because it's always patients first. And particularly for this disease, we know it's always patients first.
I find the patients highly receptive. Out of all the patients we approached who we felt like were candidates, not a single one said no. And I think if you put yourself in the patient's shoes and understand what they're going through, I think it helps to understand why. The patient has typically just received horrible news. Based on their imaging, we think that they have a glioblastoma. When we talk through the statistics on glioblastoma, patients are devastated. The prognosis is poor. What they're about to go through to get maximal survival is going to be arduous. And then after that counseling, we discuss clinical trials. And for most patients, what they describe is that it presents a ray of hope. And I think clinical trials can be like that in a lot of ways. I think it helps that we're enthusiastic about the trial. I personally am enthusiastic about the trial. And I think that they key in on that. And they see this as something that's a differentiator that is special and has the potential to be a game changer for their prognosis. We did the implantation and explantation of the biodiffusion chambers in the OR, but our anesthesia teams worked with us really well. These cases were typically 15 or 20 minutes. Did it under conscious sedation, so they didn't have to be intubated. There were no additional lines. They just were made a little bit sleepy. We numbed up their belly and in and out very quickly. And it was to the point, after the implantation, patients went home, and then they came back 2 days later for an outpatient explantation surgery. And it was very straightforward. Patients had minimal, if any, symptoms related to implantation. So I think they tolerated it well.
Well, it goes back to our first comment on what makes glioblastoma so challenging. So here, the concept is you take out a patient's brain tumor that has a newly diagnosed patient. You basically prepare it by giving it this antisense oligonucleotide and radiate it. And basically you're giving the patient back in their abdomen, marsupial pieces of their own tumor. And that generates this antigen recognition and immune response. So it's really going back to allowing our body to survey this tumor outside of the blood-brain barrier, and then to harness the power of our immune system to attack and kill it. And I think that is should play a role. And I'm looking forward to getting the results of the trial so that we can implement it for more and more of our patients.
I think generally speaking, if we can achieve an additional 4 to 6 months for either of those metrics, we're going to feel like the needle has been moved. Of course, as optimists, we're hoping for more, of course. And, as clinicians, we're hoping for much more. When we, look in our patients' eyes and try to help them to navigate a very scary future, we're hoping to be able to say, hey, look, you and I were part of this study that really moved that needle for you.